Good day once again. This is my second talk about Intracor femtosecond laser treatment for presbyopia using the Femtec laser. In April 2007, we acquired the femtosecond laser. We did a few femtosecond LASIK flaps and also a few corneal transplants with good results. And in the next year, I became involved in a European Intracor intrastromal corneal laser treatment study for presbyopia. So what is Intracor? It is the acronym for intrastromal corneal femtosecond laser surgery. It can be done for presbyopia, myopia and astigmatism. The main advantage is the non-invasive nature of the surgery. Neither the epithelium nor Bowman's membrane is opened or disturbed. The laser, as we said, comes from Perfect Vision 2010. The Intracor treatment was developed by Dr. Luis Ruiz from Bogota, and the company provided the software. We were a part of a prospective European study in collaboration with PV 2010. The aim of the study was to determine the efficacy, predictability and safety of the treatment. Dr. Ruiz had done a significant number of these cases with considerable success, and obviously we hope to confirm the results of Dr. Ruiz. Our study protocol, which was the international study protocol, 20 patients were initially planned with presbyopia, age 45 to 60, right personality and right occupation and activities. We treated the non-dominant eye. The patient had to have a normal eye with clear media, and the astigmatism had to be 0.75 diopter or less. We aimed for the pre-operative spherical equivalent of 0 to plus 0.75. One patient who insisted on being part of the treatment was slightly more hyperopic, but we included him. There you see the examinations we had to do before the study started. And then how do we treat it? It is done deep to Bowman's, and the patient in that part of the study got 5 concentric intrastromal rings 0.4 millimeter apart. The central ring had a diameter of variation in values of 1.6 to 2.0 millimeter. And the rings become shallower to the periphery. The theory behind the treatment, there is more than one theory. The one is that the corneal architecture is changed. These rings then cause controlled weakening of the corneal fibers. The IOP could move the central cornea slightly forward and create an intracorneal multifocal segment similar to a multifocal refractive IOL. In my view, the rings probably also cause diffraction and in that way multifocality. So what did we expect? We knew from Dr. Ruiz's work that it would induce 0.5 diopters of myopia. So we had to add radial incisions to counteract this, also intrastromal. And some eyes got 4 incisions and others got up to 13 radial incisions. And we used the Ruiz nomogram. And then the treatment, practical, how we do it. There's a video which is supposed to come on automatically now. Apparently it doesn't seem to be working. So we okay. The results after 1 day, all eyes had improved near vision. All eyes had improved near vision. So that was very exciting. There was no pain or discomfort. But there was bullet number 4, variation in distance vision. 2 eyes gained distance vision, which was fine. 2 eyes showed no change in distance vision. And then 4 eyes lost distance vision the day after the operation. And we, as we said now, we treated the 0.5 diopters of myopia. And here we see the near vision between pre-op to 1 day. Blue pre-op, yellow 1 day. You can see everybody's better. The distant vision pre-op to 1 day see some of them are worse. This particular person was a lot worse than this one as well, but they were both happy in the end. Then we go to 6 months. All eyes still had improved near vision. 3 eyes had improved distance vision. 6 eyes had reduced distance vision. And then the bad one in my view is the 4 eyes lost BSCVA. The incisions were visible from the beginning, and after 6 months we could still see it. And here you have a picture of the incisions. Those are the 12 radial cuts with the circumferential cuts in the middle, the rings, and those are the radial cuts. And the patients all look like that, and after 1 year you still see the same incisions. We're still with 6 months. 6 months average improvement from compared to pre-op was 0.43. If we exclude the 2 patients who turned out to be poor patient selection, the improvement was a little bit better. And here you have near vision pre-op to 6 months, and you can see they're still better, all of them. Results over the course of 1 year. After 1 month we had an average improvement of from 0.26 to 0.59, and after a year it was 0.69 average near vision, which was good. And here you see it in a graph. This is the 1 year near vision values on the average of the patients. And the near vision pre-op to 12 months, every patient, another graph. And then we look at the happiness. Were the patients happy? 6 of my patients were extremely happy. And as you know, happiness is a combination of many factors. This patient gained from 0.2 to 0.8, but she was unhappy. And that was a combination of a personality thing and a financial thing, because we asked her, if you had to pay for the surgery, will you take it again? And she said no. He said, if we do it for you free, will you do it again? He says yes. So that made a difference. If you compare near vision pre-op to 12 months, you see once again the near vision pre-op was blue, and it's a lot better after a year. And the red ones are the unhappy patients. So this patient is good but unhappy. A comment on the happiness, 6 out of 9 were happy in spite of loss of distance vision. 2 of these effectively have monovision. They've lost so much distant vision uncorrected that they have monovision. 1 of the 9 is happy, although she only has 0.5 because it's better. 1 patient was unhappy because of loss that this patient is a man who was extremely unhappy from the beginning because he didn't gain enough and he lost a lot of distant vision. And he could see the corneal rings in front of his eye from the 2nd day onwards. And then 2 patients didn't gain enough vision. And there's another graph to just show you the distant vision, and these patients are the red ones are the unhappy patients. So they do lose some distant vision. The contrast test we did, 4 out of 9 had a notable deterioration in contrast sensitivity. 2 had an improvement and 3 had varied results. And here you have the different charts, which I'm not going to elaborate on. Complications. Loss of distant vision for distance 6 out of 9. Loss of best corrected vision for distance 5 out of 9. Less improvement of near vision than expected, 3 out of 9. Starburst and halo, everybody saw starburst and halo. But as from 6 months onward, they said it's not a problem anymore. They got used to it. And remember, this was a group of treatment of 1 eye. And here you have a graph of the starburst and halo. And as you can see from the yellow graph, after a year, it is less than after 6 months. Complications, and this is the guy I referred to, he could see the rings and he was extremely unhappy. He was 60 years old. And I looked at his eye and thought maybe he's got a cataract, and the other eye didn't have a cataract. And after a while he convinced me, and we did this cataract surgery. And he was better. But his vision still varies. So he will say to you on one occasion, one day I can read everything, I can see far, I can see near, but the next day I can't. So referring back to corneal biomechanical factors, there must be something going on there that we do not understand. Will they have the surgery again? 6 said yes, 3 said no, and for various factors. Now let's talk about what happened. In our case then it improved near vision for everybody, so it does work. But they lost distance vision, and some of them were happy in spite of the fact that they lost vision. So the 2 eyes lost significant distant vision. This result is basically a variation of monovision. And all patients had the starburst and halos, and the results tend to vary. Now, a few unanswered questions. What really happens to the corneal shape and structure? What about the HOAs? Is diffraction a factor? And other questions. What really happens to the corneal structure? We did pentacam measurements on all of them, and 5 corneas were steeper and 4 were flatter. So that can't be the reason for the improvement in vision. There you have the flatter people, flatter corneas, and they all gained lines of reading. 2 were unhappy, 1 is unhappy here, but these are steeper. This one got steeper 2.5 diopters. And best corrected vision, flatter and steeper, and you see there's no constant factor there. And this is a picture just to illustrate it. You cannot see that, but this one is a far more steeper than what that one is, same patient. And higher order aberrations, we could not get any decent maps. And the reason I thought was diffraction. And we have a churning type analyzer which might be too sensitive. Is diffraction a factor? Yes, I think so. I think the cornea looks just like the restored multifocal diffractive IOL. And one has to speculate then that diffraction is a very important factor in the function of the Intracor presbyopia laser effect. Because there's another factor. If you do refraction for these patients and you add their preoperative +2 or +225, they say, I see better. So although they can read J2 or J1, they still prefer the +250 or 225 add. Why would that be? It's because most of the rays going to the fovea are still out of focus, but there are enough diffractive light rays going to the fovea to allow them to read. That's the way I think about it. And then the questions, why do some patients get better vision? There are just unanswered questions. Why does the vision fluctuate? Biomechanical strength, the number of visions, we don't really know. They are also experimenting with 6 rings, and from my thinking, I think more rings will be better, and a bigger central zone will be better. Conclusions. Our series is too small for definite valid conclusions, but you still learn a lot. We did 9 eyes and I learned a lot. Intracor femtosecond laser treatment may have a place in presbyopia treatment. The patient selection, once again, is important. Ideal patient, 45, 55, pre-op refraction slightly plus 050, and then clear media in a healthy eye. Conclusions, the right personality, once again important. Activities is not very important, because if you do one eye only, because then you work with monovision, and if the patient understands that he can get monovision, he can do many things with that. And the patient must then accept that he may get monovision. Patient must be prepared to tolerate some loss of distance vision. Now, one of my happy patients are extremely happy, and he's got 0.4 vision for distance in that eye, which was a 1.0 eye pre-op. And the reason is he's so much better for near. Summary is good for a relaxed presbyopic with good distant vision, clear media, little astigmatism, as well as average visual requirements to test his reading glasses. He must be able and willing to tolerate the degree of halos, monovision, and loss of distance vision in the operated eye. The treatment is effective, but the side effects are still a problem. Thank you.